Welcome to Health System CIO's interview with Adar Palis, SVP of Clinical and Revenue Cycle Applications with Providence. I'm Anthony Guerra, founder and editor-in-chief. Adar, thanks for joining me.
Thank you, Anthony. Nice to be here.
All right, great. You want to start off by telling me a little bit about your organization and your role?
Sure. Providence is up and down the West Coast. So we have sites, clinics, and hospitals in 7 states. We have 51 hospitals and over 1,000 clinics. We have over 100,000 staff, many endpoints. I've been with the organization for about 10 years. In my current role, I manage all of our applications. So it's roughly about 2,000 plus applications, both on the revenue cycle side and the clinical side.
All right, very good. So you mentioned endpoints, and I think that's gonna be part of our discussion today. So you've got a program or an initiative called Easy Pass and Clinical Workstation Modernization Effort. So I'd like to ask you about that. Tell me about what it entails. Always very interested in the genesis of these things, and when I say that, I mean, we always say there's a billion things that you can do, and governance is there to help you figure out what you're going to work on, get it to line up with the strategic goals. We have a pot of resources. We need to put them towards certain things. The list is always bigger than what we can do. So we have to make a selection. You've selected this initiative as an organization. So a little bit of the genesis of how it came to be deemed, worthy of moving forward, and then tell me about it. Thank you.
Absolutely. So one of the reasons why we came up with this is that we up here at Providence really want to focus on our giving back time to our caregivers, to our providers, to our nurses, so they can spend more time with the patients. And so from an IT perspective, there's obviously things like clinical documentation, et cetera, but also endpoints, so computers. And we are getting, lots of questions and observations of why do I have to log in so many times? Why are the timeouts so short and inconsistent? Why does it take so long to log into a computer? Why is every PC different? And so we wanted to make the environment as easy as possible, so that they can spend, again, more time in Providence spending with the patients. And so that was kind of the genesis of the program, is to go out and figure out, for these endpoints, how do we make the life easier for our clinicians?
So you're really it's an investigation process to find the big dissatisfiers. We say we
Yes.
want happy clinicians. Okay,
Right.
let's do some surveys. Let's figure out when clinicians aren't happy, and we can use the word burnout. Sounds like what we're talking about here. We got we got some unhappy clinicians. When they're unhappy, why are they unhappy? Oh, this is really at the top. This is making everybody unhappy, annoying people beyond belief. Let's tackle it. What are we going to do?
Correct.
So that's part of the process. And then when you say, okay, this is something we need to tackle, take me from there to there probably are multiple ways to tackle it.
Right. So you hit on a really important point, is trying to understand what is driving that burnout, what is driving that dissatisfaction. And so really it's through surveys, but it's also going out and actually observing clinicians, watching to see, wow, that does take a long time. Oh, a nurse, you're going from computer to computer and having to log in and out, and each single time, and it's taking 5 minutes here, 3 minutes there, and that adds up at the end of the day. They end up having to stay longer to complete their documentation, and that's nothing we want to see. So once we package up that idea, then we take it forward and say, is this something that's really going to make a demonstrable difference at Providence? And certainly it did. If you look at how many endpoints and how often this happens on a daily basis, both in our hospitals and our clinics, it is something that was certainly worthy of focusing on, because it is going to make a big impact for our clinicians. And so we moved it forward. We got approval for through our normal project plans, got the resources associated with it, determined our charter and scope, and really took off.
All right, let's talk. I'm interested in this idea of, I guess, I don't know the technical term for it, but sort of a workflow study. So, as you mentioned, there's the process of tell us what's bothering you. And then there's another process of, I probably need a high level of expertise to do this. Maybe you bring in an outside organization, but observing. And the interesting thing about healthcare is there's a zillion different workflows because there's different hospitals. Things can be different at each hospital. You've got a lot of hospitals. So things can be different at each hospital. A nurse is not a nurse is not a nurse, right? They're all different kinds of nurses and all different kinds of units. So, it's almost like, all right, we have to study this one type of nurse, like, and we're gonna, because if you go too general, then you're not really addressing the workflow except for a small sliver. But take me through the whole concept of doing workflow analysis and study and just watching them and then turning that into data.
Well, you just hit the nail on the head. Is just watching them, just observing. And then if if IT sits behind this wall and never gets out into the clinics, into the hospitals to actually observe what is being done, you won't be able to pick up these things. I mean, people may not even know that, hey, there's a faster way to do. You shouldn't have to log into a computer every single time and log out. There's got to be a better way, a quicker way for them to be able to reduce that pain point. So, I mean, you can have formal studies when it comes to, clinical documentations, regulatory, those types of things. But when it comes to something as simple as a computer and an endpoint, just pure observation and watching to see that. I mean, everybody experiences that. You can see that at home. I'm sure with your significant other, sometimes you'll see something that they may not know is something that you can help improve. And that's what we saw when we observed their workflow. It's like, wow, this nurse is having to go from patient room to patient room to patient room and log out, log in, wait for it to log into the medical record. And it just was, this is something that we saw from an IT perspective that we can solve relatively easy.
Yeah, so I think it's important for people to understand that you can't just wait for people to tell you about things that bother them, because
Agreed.
we all know in our personal life, where we shop, where we go to the gym, different things we do, things that are dissatisfiers. 90% of the time, we just say, "Oh my God, that's so annoying," and we don't tell anybody because we don't
Yeah.
want to be a pain or we don't want to be seen as a problem. We don't have time for the interaction. We figured they should know, they should figure it out. So you can't just sit back. So what you're saying about what? Go ahead.
No, you're absolutely correct. I mean, and sitting there waiting for someone to put in a ticket,
Right.
that's just being reactive. It's better to be proactive at problems. So that's our focus.
Yeah, there's another level in this analysis, and tell me about this, where if you're doing observation and you see someone struggling, you do have to go a bit deeper to say, is it just this individual? So,
Right.
do they just not understand that there is certain functionality that they can use that will save them all this difficulty they're having? And if that's the case, it's a one-on-one sort of
Yeah.
counseling education tutorial. If it's everybody or if we know it's a systemic problem, like, you have to make that differentiation, correct?
Right. Correct. You need to understand: is this a training opportunity, or is this a systematic problem that is something that is occurring all over your organization, and then you need to tackle it that way.
Right. So this idea of, and tell me a little bit about exactly what you did here from a
Right.
technology point of view. And is this something that you say most places have done? Or you know what I mean? Is this something a lot of people have tackled and you're just getting to it? Or is it more, on the edge here, cutting edge a little bit?
I feel like it's more on the cutting edge.
Okay, tell me
And the
about it.
reason why is there's a couple things that we did. One, we created what's called a virtual desktop. So I can basically push out the same desktop to any of our endpoints very, very quickly.
Mhm.
So I don't need to have, because again, that was one of the issues that we saw, we observed. Every computer was set up differently.
Hmm.
And so we needed to be able to resolve that, because again, it's a tool for clinicians to take care of the patients here at Providence. And so why should it be configured differently? So we created a virtual desktop that we can just push out very quickly. That was the first step. The second step was, okay, how do I get you as a clinician to be able to log in and out very quickly with having to type in your password, username, and password every single time, wait for the system to start up and stop. And so we use badges. So we call it tap to go. So it's single sign on. So they literally use a badge reader that you attach to the computer. And then, there's all the magic that happens behind that. But they tap in with their badge. Every 4 hours, they have to type in a passcode, because we don't, in case somebody steals your badge or you lose your badge or something, you've got to still be able to log in. But you tap in. and it will log you into your applications. And then all you have to do is tap out, and that locks the computer, and you can go to the next computer, tap in, and you're right back into where you were. And
Right.
so the amount of time that it saved, especially if you, again, look at the workflows that providers go through or nurses go through, where they are literally taking care of 4 or 5 patients at a time, and they're having to go to the computer in every single room to do some documentation. Imagine having to log in and out of every single one of those. Now they just tap, and they just go from room to room to room, and it does log out. So no worries about somebody coming in after them and documenting under their name. So it will log them out, or tap them out, if you will, if they forget to tap out. So we put a lot of security measures in there as well, because we wanted to make sure that there wasn't any incorrect documentation. But the time saver, Anthony, has been amazing. You
Hmm.
would never have thought that something as simple as logging in and out of a computer, and having a consistent desktop, how much frustration and time that took away from the clinicians, and away from their time with the patients.
All right, very good. You mentioned 2,000 applications. One of the issues that people struggle with, and they're trying to move forward on, is reducing that number, right? Application rationalization. Um, I guess, there's a whole process here. It's very difficult. It's very difficult to get to sunset things that people use or say they use, or find out who's using what, get an inventory of what's being used, and try and find out where there's redundancies, and then ultimately get that number down. It's an extremely from what I hear and the people I interview, it's an extremely difficult endeavor. You could have two people using it, and those two people will say they can't live without it, and
Right.
so it always hit that wall. What are your thoughts on that? Where is that in terms of things you're trying to accomplish?
Certainly, that's a top priority, for my team. Not only from a selfishly from a maintenance team, or maintenance standpoint, to have to manage 2,000 applications, many of which are overlapping, to your point, but also from a consistency and a cost savings measure. If we have an application that we're paying for, that can support our entire organization, why pay for a second or third or a fourth? And so it is certainly a top of mind and a top priority for my team. But I will tell you, Anthony, one of the most important things here at Providence that we do is it's not an IT initiative. So for me, sitting in IT, to sit down there and make a judgment to say, I think this application will meet your workflows, is not going to work. And quite honestly, that's pretty arrogant to sit down there and think that I know what a nurse or a provider or something else, or someone else it does. Instead, it's to sit down there and go to them, understand what are you trying to accomplish with this software package, get that understanding, then do a demo, have them understand to say, well, here's something that we already have in our portfolio. What do you think? And have those conversations. It might take a little bit longer, but I think the outcome is far more positive, because they feel like they help to make that decision, versus IT coming in and strong arming someone and saying, hey, you're just going to move to this application. Just like we were talking about with, people just don't know to put in tickets. They don't know. They may not know that there are these other applications that are out there. There are more standardized applications that are out there. There are more benefits to having, one platform that is all integrated versus separate applications. They might not have that knowledge, and to make that assumption is wrong. And so being able to go to them, show them, ask them, help them be part of that decision is, I believe it's been far more successful at Providence.
So it's like a sales process. I mean, you
Almost.
basically you have to essentially, you're selling the application you would love for them to move to for whatever workflow they have, and you're saying, you're pitching it and you're selling it,
Right.
and that can be challenging.
And it's got to be, and to be honest, if what they say and what their workflow is, and the application that you are saying that you believe could replace it is not congruent, then you don't do it. Which I think is a little bit different, obviously, than just a purely sales job, because a lot of times vendors will come in and think that they know everything,
Yeah.
and that their solution will meet all their needs. If it doesn't, then it doesn't, and that's how you build trust. To sit down there and say, well, you're right. Maybe we do need to keep this application because you have a unique workflow here. There's specific state regulation that or workflow related to a state regulation, that we need to keep this application. Because again, here at Providence, we have multiple states, obviously, and so there are unique workflows that are in place because of those individual states. And so I think it's important to be able to take a step back and not just say, "Hey, this is going to replace what your workflow is," and not really hear their feedback, hear their response, and really take it seriously.
Yeah, and it's tough to move the needle because and almost because of that. And you can't, you wouldn't want marching orders given to someone like yourself that says, "I need you down 15%
Right,
at the end of the year," right? I want that number down, that 2,000 number. I want you down 15% in 12 months.
right,
That
right.
that would be tough marching orders.
Well, and especially if you also come and you say, "Hey, I want you you're going to use this application, and oh, by the way, it's going to be 20 more clicks than what you're doing today." Is that really helpful to them? Again, going back to what we started the conversation about was clinician
Well,
burnout and ensuring that people aren't spending more time in front of a computer and less time with the patient.
Well, that's an easy one. That's an easy one, but it can get much more subtle than that. It can get to it's not 20 more clicks, it may not be any more clicks, maybe 3 less clicks, but oh, but I don't like it. I'm not used to it. I don't like it. And then you go, well, all right, I don't know where to go with this now. So it's just it's not easy. That's why this is a really hard problem. And this is why we have to be extremely careful about bringing in new applications,
Agreed.
right? That
Agreed.
why if we're gonna have if it's so difficult to get them out, we need a really high bar to get them in. Does that make
Right.
sense?
Absolutely. And I think to your point, it's got to be a question of, well, don't tell me about the application. Don't tell me about the solution. Tell me about what you're trying to accomplish. What is it that you need? And then see if there is something that we already have. Because to your point, once it's in, it's hard to get it out.
It's yeah, it's a challenging issue. Everybody wants to do better at it, but it's just it's almost from when I talk to people and you almost hear it in their voice like it's a black hole where you could
Yeah.
waste all your effort and maybe not move the needle much. So I don't
Agreed.
know if it's a right. I don't know if it's a place to spend, a whole chunk of your time.
Right. I mean, I think that certainly in our case, we have too many applications. It's worth it, but sure. I mean, also if you have an application that there's really not a lot of variability, there's not a lot of cost. Is that really the best and highest use of your limited resources? You're
Right.
absolutely correct.
All right. Let's talk a little bit about another huge issue that I find very interesting, and it's training on systems.
Yeah.
Um, it's a hugely important issue, and we've seen in different class reports things about how important it is and how it can move the needle quite a bit around burnout and
Right.
clinician satisfaction. You have the idea of new employees that need to be
Right.
trained up on things, which is kind of easy because you can kind of formalize that, the batch of education they're going to get. You have the introduction of a new system, and again, everyone's got to get that training.
Sure.
Then you have different upgrades, some of which are minor and don't require any training, some of which are major. You need good communication with your vendors so you understand what's coming in terms of the
Right.
upgrade, and hopefully they're coaching you up on what train if any training needs to be done. What we don't want we don't want frustrated clinicians, and this is
Right.
one area you can get frustrated clinicians if things change without the proper education around it.
Yeah.
um, so I want like your thoughts on that whole thing.
I mean, that is a huge issue. So EMRs and other clinical systems are very complicated. Even when you go live with one, putting someone through 4 8 hours of training is just scratching the surface. They're trying, as you mentioned, they're trying to learn new workflows, new systems, etc. I mean, you can only absorb so much at once. And at Providence, we have an amazing clinical informatics team. It is not a once and done. It is something that we need to circle back, especially since now, hey, it's been 6 months since you started, and now you're a little bit more comfortable with the system. Let's teach you some of the shortcuts. Let's teach you
Mm,
some of the opportunities to be able to reduce some of the keystrokes and stuff like that you have. It's a constant state of learning. putting out tip sheets, putting out, hey, go sending emails. Those are just not ways in which you're going to get to clinic. It is literally going to them. It is rounding on. It is talking, which is what our informatics teams do, and sit down there and understand. Okay, you've been using the systems for a year or two. Let's sit down there and again, goes back to the observation. I see that you're not using this shortcut or this fast track process that you could have, or this order set, or whatever you name your tool. You may not know about it. So let me show you, and here are some of the tips. I think they do a fantastic job. I think I've seen other organizations where all they do is they do their initial training. They plop a site out there for self-serve where you can go and look at a to-do or tutorial and stuff like that, and they just leave it at that. And that, again, that's not being proactive, that's being reactive. That's waiting for someone to be able to go and figure out how can I use the system more efficiently. Instead, it's going and going to them. It's constantly looking for opportunities to see, okay, how do we improve this workflow? Maybe it's through an upgrade, as you mentioned. Maybe it's through a new piece of technology like ambient listening, those types of things where, okay, well, we want to reduce all of these things. Well, that's where our informatics team is really important, because it's made up of nurses, it's made up of providers. So they understand the workflows. They do have those constant check-ins and connections with our teams and with the clinicians, and so they can help to be able to translate and understand. And so it's you can tell I'm pretty excited about it, just because I think it's a constant state of learning. I don't think just giving someone 8 hours of training and just leaving them on their own to try and figure it out is acceptable in today's age.
Yeah, I like the idea of the sort of stages of education, that you don't try and give them sort of everything at once. You say, or we're going to teach them certain things, basic things at the beginning, and we're going to have periodically, we're going to go deeper. That's really
Right.
interesting. Yeah.
Right. I mean, and it's a constant, because, as you mentioned, every system, you name it, they come up with updates and stuff like that. And so again, I always look at a clinician's, they got a day job. Their focus, their priority is taking care of patients. So how do we make their job as easy as possible with these tools? And by sitting down there and being proactive and pushing this stuff to them, as opposed to waiting for them to come. Again, what we talked about, waiting for them to put in a ticket or call and tell us, it's just, that's not acceptable, and that's what leads to burnout.
Yeah, tell me about the interactions between some of the parties involved here. You have theoretically a vendor, right? And that's the system. They're responsible for knowing what they're pushing out to you. They're responsible for, I assume, having some idea of how people should learn how to use their system. And I
Right.
don't know if they provide that, if they say, all right, you're licensing our software, we're going to send our people in to train your users. I'm not sure how that works. It may be vary by vendor. You
Right.
have your internal team of people that do training, which are the informaticists. So
Yep. It's under
they
the informatics.
they do the train. Maybe they have to get trained on the stuff first. So maybe they're the ones that get trained by the vendor, and then they train your users. And then you may have a third party vendor, another company that specializes in
Right.
providing training. So tell me about these entities working
Right.
together.
Mainly that the only time you really want to bring in a vendor to do the training, if it's a very specialized or small group. I mean, an organization as large as Providence, it's not realistic to think that a vendor is going to come in and train across 7 states. So we use a lot more of what you talked about, where you have the informaticists get the training and they can customize the training to the
Hmm.
specific workflows.
Hmm.
Get some of the other stuff out of the way, and only the stuff that you really need to know to hone it down, so it's much more effective and important. And I think that that's the key, and that's important for our clinicians to be able to get. Okay, I need what's important for me for my workflow. Take all the 25-page manual and put it into my workflow, and show me how I can use the system to be able to take care of my patients. And so, to your point, we do need to work obviously with the vendor. We need to get the updates. We need to know what is changing. You're going to move my cheese. This button's going to go from here to there, and whatnot, and why. And so we need to get that training, but then really rely on Providence's team, Providence's informatics, to really customize that workflow to to the clinicians so that they can really, it can have a lot more of an impact. Because you have an outside vendor, outside company, they don't know our workflows. They don't
No.
know our organization. And so it's usually pretty, I've seen other organizations where they brought in, contractors, et cetera. And I get it, sometimes they're going with a huge go live, et cetera, but they aren't familiar with your workflows, your decisions, your governance. And so it's usually pretty vanilla.
All right, very good. Let's go back a little bit to the idea of controlling the applications that are coming in that are being purchased. We don't want things purchased. We don't want applications purchased outside of sort of a centralized function, I would imagine. When you're so big, you need to get that locked down so that things aren't popping onto the network at this region in this hospital, because people
Right.
can buy things on their credit card and put them in the cloud and right. And so,
Yeah.
we want that 2000 number not to move unless we want it to move, unless it's extremely well thought out. One of the dynamics that people joke about is somebody goes to a conference
Right.
and they go to a vendor dinner or some sort of thing and they're like, I need it. I love it. I need it, like a kid at Christmas. And I don't know if they send you an email with a link and say, hey, I need this, or however they're trying to get it purchased. And then there has to be a process, I'm sure, of, you know, it's probably got to meet certain bars before anybody even considers looking at it. And then there's all kinds of bars and hurdles,
Mhm.
rightly so, but hopefully reasonable, because occasionally maybe there may be that golden application that's new and hey, we do need this. So tell me a little bit about that whole process.
Yeah. I mean, I think it's really important to have a good relationship with operations.
Hmm.
So from an IT perspective. So again, I don't want to stop anyone from going to conferences. I don't want to stop anyone from having conversations and be able to understand and broaden their horizon, because we're not, IS isn't perfect. We're not all knowing. We can't know every single application does everything, and we certainly don't know what every single pain point that someone might experience in operations. And so we want to instead be able to create that communication pathway. So we have what are called program managers at Providence. And so these program managers, they're under my team. They are dedicated to service lines. So they work with these service lines. And when I say service line, I mean like cardiovascular or surgery or some other service line or revenue cycle, to sit there and understand. Again, goes back to what we said is, tell us what you're trying to accomplish. I know you saw the shiny new object. It sounds wonderful, etc. But let's take a step back. Let's not solution. Let's sit down there and say, what are you trying to accomplish? What is the outcome that maybe this software sparked that you may not have thought about? And then that's where we go through our governance process to say, okay, well, let's look at our portfolio. Let's see if that's something that's really important for you. Let's create a roadmap around it, and let's implement. If we don't have that software package in our portfolio, then yeah, let's look at this vendor. But let's look at this vendor for our entire organization, because if it's great for you at hospital X or clinic Y, it's probably great for everyone else. And that's where I think having that relationship with the service lines, we can bring it back and say, okay, well, surgery, let's have a discussion, or cardiovascular, let's have a discussion about all of our cardiovascular clinics, not just implementing this at one cardiovascular clinic. And so that is something that is relatively new, probably in the last 3-4 years at Providence, having these program managers to be able to communicate these changes on a wider scale, because it's also really beneficial. If we have this great idea and this great, whether it's software or it's implementation or configuration of an existing software at a clinic in Montana, someone in the same clinic in California or in Oregon or in Texas could also take advantage of that. So why not make sure that we can roll this out to everybody? And I think that is something that we've really opened up those lines of communication.
Yeah, and we want governance to be our friend in IT,
Right.
because we want governance to make the decision, a balanced governance that involves
Right.
users, executives, and all kinds of voices. So it's not Otter saying, no, you can't have that. It's
Right.
your peers. On an organization level, your peers have deemed that we have something that covers most of what you're looking for, and it's an integrated product that we have. What you're talking about would be sort of a one-off and require this and that, right? And so on a large level, the organization has deemed that we're not going to move forward with this. So it's not Otter saying IT said you can't have it.
Right. And because and it shouldn't be, right? I mean, it should be a partnership, and that's the whole point. Is that Providence, we really believe that IT and operations need to
Mhm.
have a partnership. It
Yeah.
can't just be IS as being, a dictator and saying, nope, you're not going to get that application.
Yeah, people still make missteps in this stuff, which is kind of interesting. I mean, we've been talking about this for 15 years, 20 years, and I still spoke to someone the other day who talked about a project failing because it was an IT project and
Right.
he didn't get operations in front or with him side by side. And it's like it was amazing to me. It still happens. Like
Yeah.
it still happens, and you wonder how does that happen? But it still happens. So it's still something
Yeah.
you got to be careful of. I don't know if we can
Always.
just all of a
It,
sudden
it
like you tell me how does it happen when it happens?
I mean, I think sometimes somebody goes, in my opinion, goes too fast.
On
There's,
IT, on the
on
IT
IT.
side.
Yeah,
Yeah.
I think they just like, really want to do this, and now off I go. And again, you would think that lesson learns, from the past that shouldn't ever happen. But you're right. I mean, I think once in a while on a blue moon, I've seen other organizations where they've done something like that, and it's been a pretty spectacular failure.
And what about that? We touched on it before. We're almost out of time, but we touched on it before. That gray or shadow IT. That's another problem. We talk about these thorny problems. Application rationalization is a thorny problem. The
Yeah,
shadow IT stuff is still a thorny problem.
right,
Making sure things don't get purchased outside of appropriate governance lanes is still a thorny problem, and it happens.
right.
And I've spoken to executives who talk about, yeah, well, it shouldn't happen. We do our best to make sure it shouldn't happen. But when it does happen, you still don't get to go shut it off and go yell and shut it off. It's still, okay, you snuck it in the back door. Now we got to get cyber to look at it. Now we got to do this. And
Right.
because you don't go yell at your clinicians.
No,
So,
no.
what are your thoughts there?
Yeah, I mean, you're exactly right. You don't want to ever go and yell. Yeah, it's a little bit frustrating when something slips through like that. But it's again, there's two. The way I look at it, there's two things. One, obviously, they're trying to solve for an issue. So at the end
Right.
of the day, we're here to support operations. We're here to support our clinicians. So clearly, they have a need or a concern. So that's got to take top priority. And second is, I see it as okay. Well, then we haven't properly ensured that we have great communication back,
Right.
that they felt comfortable coming to us and saying, hey, here's my issue. I need to solve for this issue. So is it because we just don't have great path of communication? Do we have too much governance stuff in the way? Or, whatever. I think it's an opportunity to look introspective to say, okay, how could we improve this situation that doesn't happen again? Versus to your point, going and yelling, that's just not going to get anywhere anyway. So,
Well, I think you're 100% dead on correct. And they may just say, we didn't know we had to ask, right?
right, go, you're correct.
I thought it was fine. I didn't know I did anything wrong. So it could be
Absolutely.
it's something as simple as that. Okay, my final question. Based on, your experience, things that you've found that have helped you be successful in your role, your best piece of advice for someone in a comparable role.
Constantly learn. So never think that you're done. So I think we've hit on that probably 10 times in this conversation, which has been fantastic. Is that clearly there's always an opportunity to iterate and to get better. And I think it's having to be in a position of I got to constantly be learning, constantly be adapting to the changing healthcare landscape.
Well, this has been a lot of fun, Otter. I really appreciate you taking the time to talk today. I hope we can catch up again in the future. So thank you so much.
Absolutely. Thank you, Anthony. It was a pleasure to meet you, and I get a chance to talk a little bit about Providence. So thank you.
Have a great day.
You too.